So welcome back, everyone, and we're about to start the second round of 4 presentations that we have from our trainees. As you heard, they're 3-minute presentations, and then we'll have a chance for some questions at the end. And so I'd like to start by welcoming Laura Critch. She's here from the University of Ottawa. Welcome.
Good afternoon, everyone. My name is Laura Critch. I'm a master's student at the University of Ottawa, and I'm doing this project as part of my directed study with the Royal Mental Health Hospital in Ottawa. So the title of this project is Exploring the Mental Health Needs of Women Residing in Violence Against Women Shelters in Ottawa, Ontario. This project started last year, and we have just finished up data collection, and we're now on the analysis phase. And it's a collaboration between researchers at the University of Ottawa and the Royal Mental Health Hospital. So numerous studies have confirmed the experiences of violence that precede women accessing violence against women shelters are highly correlated with mental health issues, predominantly mood and anxiety disorders, including PTSD and substance use disorders. Unfortunately, for a number of historic, bureaucratic, and philosophical reasons, there's a lack of integration between anti-violence, mental health, and substance use sectors. The main goal of the research is to advocate for an outreach counselor that will be dedicated to the violence against women shelters in Ottawa and help mitigate some of the siloing of services in these sectors. Data was collected from all 6 violence against women shelters in Ottawa, including the Francophone shelter and a First Nation Inuit and Métis shelter. 30 in-depth interviews and 1 focus group discussion were conducted with the women, and 6 focus group discussions were conducted with the frontline staff at each shelter. Before beginning the interview, all the women completed 3 questionnaires that assess their physical and mental health functioning. The patient health questionnaire is a multi-purpose instrument for measuring the severity of depression. As you can see, the majority of women fell into the category of minor and major depression. The Somatic Symptoms Questionnaire, or PHQ-15, is a screening instrument for somatization syndromes. The women fell fairly equally into low, medium, and high somatic symptoms. Finally, the women filled out a PTSD checklist. 22 of the 30 women, or 73% of the women, screened positive for PTSD. Crystal describes her mental health experience. Then I had depression that time, but again, I didn't know what depression mean. I just feel I want to be alone. I don't want to see people. I don't want to see sun. I want covered all the windows. I don't want to answer the phone calls, even from my family. From the interview data, the women and staff unanimously identified an unmet need for mental health services in violence against women shelters in Ottawa. The staff expressed concerns of role conflict, wait lists, need for in-house counselors, stigma, shelter living environment, and intergenerational trauma. For the women, the barriers to obtaining timely and appropriate mental health services were caused by health system delivery issues, but also by the compounding social factors related to the women's complex situations. When asked about discussing her mental health, Andrea said, "Especially when you have a child, it's very difficult to talk about this stuff because of fear. You're afraid of what's going to happen to your child, and is CAS or someone else going to say you're not competent to be a mother? Or sometimes what you're feeling is truly horrible, but you would never act on those feelings or thoughts just to be able to feel like safe to tell someone. And is it truly going to be confidential?" We will use this data to advocate for more mental health services in violence against women shelters. But one solution to this problem that was actually identified by the women in our study is storytelling. Many women said the best part about being in shelter was meeting other women that had experienced similar trauma and were dealing with the same psychological effects. We are now hoping to set up an online platform for women to share their experiences with violence and how this has affected their mental health. So far it's been inspiring to listen to the stories of these women, and I'm very excited to lift up and highlight their voices. Thank you.
It's from the University of Ottawa, and we're going to have Elise Fortier.
All right, good afternoon, everyone. I just wanted to give a quick trigger warning that I am talking about sexual violence, so if you're anyone that wants to step out of the room, I invite you to do so now. So my name is Elise Fortier. I'm a PhD candidate at the University of Ottawa, and today I'll be talking about the experiences of young women living in Ottawa with reproductive coercion and the implications of digital technology. All right, So what is reproductive coercion? Reproductive coercion is a term that describes a range of behaviors that exert control and power over someone's reproductive and sexual health choices. It can look like contraceptive sabotage, so that's when someone, for example, hides your oral contraceptive pills or removes your contraceptive patch. It can look like a forced pregnancy or a forced abortion. It can also look like someone refusing to talk about safe-sex practices or a refusal to wear a condom. And it can also look like someone intentionally transmitting a sexually transmitted infection. Young women are especially at risk of experiencing reproductive coercion and face unique social barriers when trying to access services. These barriers include stigma, financial barriers, and also lack of access to health and service information. So in partnership with Planned Parenthood Ottawa, we conducted a qualitative study where we conducted 25 in-depth interviews with young women who self-identify as being women and also self-identified as having experienced a form of reproductive coercion. Many of our participants actually said that they experienced multiple forms of reproductive coercion. So I wanted to share a few of our findings with you. First, a lot of our participants voiced that they did not realize that they were experiencing reproductive coercion at the time. They knew that something felt wrong, they had that icky feeling in their stomach, but it was only once they spoke to someone that had a similar experience or did research online that they realized that they were actually experiencing a form of sexual violence. Many of our participants experienced non-consensual condom removal, also known as stealthing in the media. A lot of our participants voiced that they felt betrayed, angry, and disrespected when they found out that this had happened to them. Also, many of our participants met their abusers through dating websites or dating apps such as Tinder. This was quite common. And finally, all of our participants voiced a significant need for more comprehensive sexual and reproductive health education and information to be available online, since now in Ontario we don't have these topics covered in our sex ed curriculum. They want this information to be tailored to all genders and all sexualities and covers topics such as healthy relationships, the full spectrum of sexual violence, consent, and access to more information and resources. Many of our women voiced the need or the desire for an online interactive platform where they could share their stories of reproductive coercion or of sexual violence. They said that when they were experiencing reproductive coercion, it was so helpful to them to find someone with a similar story. It was very validating. So this is something that we want to work towards too. So I want to thank the Women's College Research Institute for funding our project and our amazing research team. Thank you.
So thank you. And now we'll have Nicola Brogan from the University of Ottawa.
Feels short. Okay. Good afternoon, everyone. My name is Nicola Brogan, and I am here to discuss with you today my research on exploring adolescents' experiences using contraception in rural Ontario. There we go. Yep, sorry, thanks. So in rural, remote, and northern communities, our citizens often lack access to health care. For women specifically, they've experienced barriers related to geography, cost, and the shortage of providers. Then for adolescents, these barriers are compounded by the difficulty in navigating a complex healthcare system. Now consider these circumstances for sexual and reproductive health. The objective of our research was to document adolescents' experiences using contraception, to identify their knowledge level surrounding contraception, and then also to identify avenues for improving services and their access to information. In times where adolescents are glued to their smart devices, it was evident that our greatest success would be in recruiting via social media, an online survey, and then using remote communication for our interviews, either by telephone or Skype as their preference. We used the online survey to recruit our interested participants for the interviews. After 6 months of data collection, we had just enough participants to begin our analysis. We had 165 survey respondents. We conducted 21 in-depth interviews with our adolescents, and I also interviewed 11 key informants on their professional experiences across the province. From our survey, majority of our participants resided in rural areas of central Ontario. Approximately 80% of them had ever used contraception, and unsurprisingly, the majority of them were using oral contraceptive pills as their most recent option. For our interviews, we emphasize on their actual experience and their information outlets. So for many of our participants, their mothers actually influenced their decisions surrounding contraception. This was quite different from our previous research. But despite the involvement of their mother, many of them privately prioritized their needs for using contraception. And so for some of them, that meant privately prioritizing the need for a prevention of pregnancy, whether or not their social networks accepted that or believed in that. And unsurprisingly, we found that the education received by our participants was limited. Many of them spoke about the vagueness of their health classes, and of particular concern, we noticed some inconsistencies in the curriculum that was taught from school to school, whether that be by region or by private versus public versus Catholic systems. So what can we do with this information? Our first objective is to publish 2 electronic manuscripts that will be geared towards stakeholders and professionals within the field. But how do we reach adolescents? Using the great ideas of our participants, I hope to vet out a few options that will be able to disseminate this information in order to ease their navigation of the healthcare system and also provide accessible information. Maybe this will be through a centralized website platform that provides accessible information, or maybe this will be through augmenting clinical telemedicine in order to address the shortages in resources and time. But what's important about this is finding the right tool to complete the job. Thank you.
Thank you. And the last presentation in this series is by Barbara Cheesy from the University of Toronto.
Hi, everybody. Thank you very much for having me here. So I'm presenting my PhD research, mobile phone-based peer support to prevent postpartum depression among adolescent mothers, and it's a pilot randomized controlled trial. So postpartum depression is a particular type of depressive disorder that can occur any time in the first year after a mother has a baby. Adolescent mothers are a particularly vulnerable maternal group who are at approximately 3 times greater risk for developing postpartum depression compared to adult mothers, and the prevalence is approximately 38%. Now, postpartum depression is deemed to be a major public health concern because there are serious negative consequences not only for the mother, but for the baby as well. And one of the biggest risk factors for mothers to be, young mothers to be able to develop postpartum depression is a lack of social support. So what these young mothers are saying frequently is that they experience a sense of abandonment by other mothers, by other friends in their peer group, and that the peers that are not abandoning them don't understand their situation because they don't have infants of their own. Currently, there's no interventions that exist that increase social support to try to prevent postpartum depression among adolescent mothers. And therefore, the goal of my research project for my PhD was to address this research gap by creating and testing a mobile phone-based peer support intervention. So the design of my study was a pilot randomized controlled trial. Participants were recruited in Toronto via Facebook and also via my community partner, the Young Parents No Fixed Address Network. And they were randomly allocated either into an intervention group or a usual care control group. Participants in the intervention group received peer support from a trained peer mentor, and peer support is the provision of 3 salient components. The first is informational support, which is giving some advice and knowledge, emotional support, which is attentive listening, and appraisal support, which is the provision of encouragement. Mobile phones were loaded with a secure app that was developed by a mobile health company called QOC Health, and was provided to all participants and all peer mentors in the study. Peer mentors were matched with participants, and the mentors provided individualized peer support by texting and voice calling on the mobile phone during the participants' last trimester of pregnancy and for 3 months postpartum. And the primary outcomes that were measured were feasibility and acceptability of the intervention, and secondary outcomes were looking at depression scores, anxiety, health service utilization, and social support. So in terms of some of the results, so there were 40 pregnant adolescents who were recruited and randomized, and the mean age was 21.3 years. The primary outcome results showed that mobile phone peer support was feasible, and there was a high participant retention rate of 82.5%. The intervention was also very acceptable to the young mothers. 100% of the young mothers said that they were either satisfied or very satisfied with the peer support intervention and that they would recommend it to a friend. Out of the 3 components of the peer support, the one that was most frequently delivered from the peer mentor to the participant was emotional support, and this occurred in 92.1% of contacts. And not surprisingly, the majority of contacts were delivered by text message, and this represented 93.1% of all contacts. In terms of looking at depressive symptomatology, after controlling for baseline depression scores, we saw that the mean depression scores were lower in the intervention group compared to the control group. There were no differences between results for anxiety, social support, or health service utilization. So in conclusion, the results show that the mobile phone-based peer support intervention was feasible and acceptable way to provide support during the postpartum, the prenatal and postpartum period, and that it may be an effective way of preventing postpartum depression in these young mothers. However, a full definitive randomized control trial is warranted with adequate sample size to test this. Thank you very much.
Can I ask the presenters to join me? And people start thinking about your questions. Do we have questions for the group? Yes, I see a couple of hands. Yeah.
Hi, okay. Wonderful presentations, everybody. So this question's, Sure. So this question's for Barbara. I love what you've achieved with this project, and I think we always hear that peer support is so important, but something that shies us away from it when implementing is how do you moderate and control for like the quality that these peers are, supporting each other with, the types of text messages, things like that. Could you comment on that?
So for this study, I actually recorded every single text message and voice message, and that was more for safety, but as well as quality control to be able to encourage how the mothers were, what type of support they might be providing, and if they need any assistance. What I found was that the mentors were incredibly gifted to be able to provide support. The participants didn't want to have professional support. They wanted to have peer support, so they could communicate it in a way, even if it was about, what are you watching for TV tonight? It wasn't about what type of support. They didn't have to have a right answer. They just needed to be there to have somebody to listen to. And sometimes they didn't even need to contact that peer mentor. Just knowing somebody was there was good enough for them to know that was a way of them perceiving that they were receiving support. So, so I found that actually that the quality of the support that was provided overall was excellent. Yeah, thank you.
Thank you. Any other questions? Yes. I'll bring the mic and you can speak loud too.
Thank you so much for your presentations, you recruited participants through social media. So I was wondering how effective is it for your studies of using social media in order to recruit participants? Do you find it's much better than in person?
Yeah, I can comment to that. So we did use a community-based strategy to recruit our participants. So we posted flyers throughout the Ottawa community, but we also posted through social media, also used Kijiji and Craigslist ads. We found that although we posted flyers all over, a lot of participants came through Kijiji ads, surprisingly. I'm not sure exactly the reason why, but it has been really effective on different studies that we have worked on.
Do you want to comment as well?
I'm going to comment because I worked with a very different population. So the adolescents I worked with were 13 to 19, and I can say that social media was actually very difficult. I thought it was going to be great, but many of them are, especially in rural communities, restricted to internet access. So I found that the groups that I was adding myself to on Facebook, for example, had mothers and other parents not so keen on the topic of talking about contraception and sexual health. So I had to be really careful, and I actually had a couple members, message me directly being like, that's inappropriate, you shouldn't be preaching this. So it's a little bit different when you're working with a younger community, but the 19-year-olds were extremely receptive to it.
Any other questions? Yeah, last question.
Again, great presentations, everyone. I just had a question for Barbara, actually. So I've been working with the distress centers for quite some time now, and I know that a lot of our outreach with adolescents is, again, largely through text message. It kind of makes sense that about 91% of your correspondence was through that. But also, since there's so much emotional support that's also given, did you potentially reach out to like suicide hotlines or crisis text message support systems to maybe integrate some of this training potentially so that members, over a long period of time might be able to reach out to those centers?
So the mentors received a 12-hour training program, and they had a manual for resources of where they could reach out to if they felt that that was needed. There wasn't, so in terms of the question, that was one part of the question. But yeah, so in terms of them having it embedded for longer term, that they had that resource available. There was a couple of times that they reached out to me just to double check to see whether or not they should have done anything different or they should be contacting another resource. So it's important to have some type of backup system for the mentors to be able to provide to them. So in case that there would be some extra support that's needed, so they know the adequate resources that they can refer to.
So thank you very much. And I know there's probably more questions that we can talk about in the break. So thank you for your excellent presentations.